Today we are going to discuss fluoroquinolones. First of all, we will look at the history of the fluoroquinolones. Fluoroquinolones originate from the nalidixic acid that is actually a quinolone. If we look at the structures of the nalidixic acid, we will see the presence of the quinolone ring in it. Nalidixic acid discovered in 1962 during the research of the chloroquine. Chloroquine is basically a malarial drug. Nalidixic acid was initially used for the urinary tract infections, but due to its limited potency and the spectrum, in the 1980 series, the additions of the fluorine atom at the carbon 6 position to the quinolone ring was added. So if you look at the structure of the quinolone ring, so at the 6th position you will see the additions of the fluorine atom. Now after the additions of the fluorine atom to the quinolone ring, it will become the fluoroquinolones. So basically, there is one difference between the quinolones and the fluoroquinolones. If we add the fluorine atom at the 6 positions of the quinolone, then it will become the fluoroquinolones. So most important fluoroquinolones is the ciprofloxacin. Gained widely spread popularity and remains in use today. Next, if we look at the structures of the fluoroquinolones. So fluoroquinolones shares a common core quinolone nucleus that is common in the quinolones and the fluoroquinolones. At the 6 positions, you will see the presence of the fluorine atom. This fluorine atom increases the bacterial penetrations and the DNA guidase binding that we will discuss later. And at the 7th position, you will see the additions of the piperazine. You will see the additions of the piperazine that actually increase the activity against the gram-positive bacteria. At the R1 side, at the R1 side, you will see there is increase in the spectrum of the fluoroquinolones. So basically, fluoroquinolones has bicyclic core. Next, if we look at the generation, first generation, you will see the nalidixic acid, that is quinolone, and it is effectively good for the gram-negative urinary pathogens. Next generation is the ciprofloxacin and the norfloxacin. It is good for the gram-negative bacteria, but it can also cover the limited gram-positive bacteria as well. Third generation, you will see the levofloxacin that is good for the gram-positive as well as for the atypical pathogens like chlamydia. Fourth one is the moxifloxacin and the gemifloxacin that is good for the anaerobes and the resistance gram-positive organism. So these are basically the 4 generations of the fluoroquinolones. Next, we will look at the mechanism of action. First of all, we will look at the important or the normal mechanism of action of the replications of the bacterial DNA. So two most important replicative enzymes, DNA guidase, also known as topoisomerase 2 and topoisomerase 4. In the replications of the bacterial DNA, DNA guidase prevents the supercoiling of the DNA. Here is the DNA of the bacteria, and DNA guidase helpful in the prevention of the supercoiling of the bacteria, specifically in the gram-negative bacteria. And on the other hand, topoisomerase 4 decatenate or unlink the replicated bacteria. As we know, during the replications of the DNA, you will see the formations of the two daughter DNA. And topoisomerase is helpful in the unlinking of these two daughter DNA. These are basically good for the gram-positive bacteria. These are the normal mechanism of actions of the DNA guidase and the topoisomerase 4. But when the fluoroquinolones block both of them, then ultimately when DNA guidase won't work, then ultimately you will see the increase in the torsional stress in the DNA, and ultimately you will see the breakage of the DNA. And if we look at the topoisomerase 4, when topoisomerase activity blocked by the fluoroquinolones, then ultimately daughter chromosome won't separate from each other. So ultimately DNA go towards damage, and you will ultimately see the death of the bacteria. So that's why fluoroquinolones is basically a bactericidal antibiotic. Next, if we look at the resistance, mutations in the target enzyme like mutations in the DNA guidase and the topoisomerase 4 that actually reduce the drug binding. When drugs do not bind to the DNA guidase or the topoisomerase 4, then there will be the no hindrance in the replications of the bacterial DNA. Second is the efflux pumps. Actually, bacteria overexpress expels fluoroquinolones from the bacterial cell. When there is no fluoroquinolones inside the bacteria, then there will be the no actions of the fluoroquinolones inside the bacteria. Plasmid mediated resistant PMQR. Genes such as Q and R confers low level resistance. That is actually resistance generated by the plasmid. And important notice, resistance is often driven by inappropriate use and the overprescriptions of the antibiotic. Next, pharmacokinetics, absorption. Fluoroquinolones very well absorbed orally with bioavailability exceeding 70%. Next, distribution. Widely distributed in our body like the lungs, prostates and the bones and other tissues and the body fluids as well. And if we look at the metabolism and excretion, ciprofloxacin excrete renally, means through the kidney, and moxifloxacin is specifically excreted through the hepatic metabolism. Half-life means 3 to 12 hours. After 3 to 12 hours, fluoroquinolones in our body starts reducing. Next, pharmacodynamics. Fluoroquinolones exhibit concentration-dependent killing with a prolonged post-antibiotic effect. Means if we increase the concentrations, then the killing of the bacteria will be good. And the fluoroquinolones will give back post-antibiotic effect. So most important thing, peak MIC, minimum inhibitory concentration ratio, and area under curve over minimal inhibitory concentrations are good for the fluoroquinolones. If you look at the graph, on the x-axis you will see the time, on the y-axis you will see the concentrations. So two most important thing which you have to remember about the fluoroquinolones. Here is the maximum concentration over MIC ratio. So this is good for the fluoroquinolones. If the ratio between the high peak concentration over MIC, then the killing of the bacteria will be good. If the ratio between the AUC over MIC, then you will also see the increase in the killing of the bacteria. Next, if we look at the clinical uses. So for the urinary tract infections, you will see the complicated and uncomplicated UTI, you will see the ciprofloxacin and levofloxacin is good for it. Respiratory tract infections like community acquired pneumonia, levofloxacin and moxifloxacin is good for it. Gastrointestinal infections like traveler's diarrhea, shigellosis, an infection caused by the Salmonella and Campylobacter, you will go towards the ciprofloxacin antibiotic. Skin and soft tissue infection like cellulitis, diabetic food infections, levofloxacin and the ciprofloxacin will be the drug of choice in that case. Bone and joint infection, osteomyelitis and septic arthritis, ciprofloxacin and levofloxacin. Anthrax and bioterrorism related infection, Post-exposure prophylaxis and treatment. Ciprofloxacin is basically FDA approved for anthrax post-exposure prophylaxis. Prostatitis, acute and chronic bacterial prostatitis, that is again ciprofloxacin and levofloxacin, multi-drug resistant infection caused by the gram-negative bacteria, dalafloxacin and the ciprofloxacin. But just keep one thing in your mind, these clinical uses can be vary according to the patients and after the culture. Next, contraindication during pregnancy and the breastfeeding, because fluoroquinolones damage the cartilage and the bone. Children under the age of 18, because fluoroquinolones increases the risk of growth plate toxicity. And next, hypersensitivity, contraindicated in patient with prior allergic reactions with the fluoroquinolones. Adverse effects, GIT tract like nausea, diarrhea, central nervous system like headache, dizziness, seizures, tendinopathy, tendonitis, and rupture, particularly in older adults or those on corticosteroids. QT prolongations, arrhythmic. Patients can also face the risk of the QTC prolongation. Photosensitivity or toxicity increased by the fluoroquinolone. And next is the peripheral neuropathy, like numb lungs and tingling. So this is all about the fluoroquinolones. If you still have any question, you may ask in the comment section.